Well, I think the team did a pretty good job for having absolutely no warning we were going to do this today. Some of the team members have been through this before, and we're rip roaring and ready to go. But basically, the nurse coming in ensured that the patient was not okay, did not have a heartbeat. Not only did she rub his chest, but she also felt his carotid artery. At that point, she was able to confirm that there were no signs of life. And the first thing you do, alert. If she was with somebody else, they could have started compressions right away, but you got to let the team know. So she had to leave. She called the code. I'm sorry, the receptionist called the code. That alerted the entire campus that there was an emergency going on. So after she radioed, the rest of the team came in. They swooped in. Someone brought the cart. Someone pulled the AED. Someone got the gurney, and they started going. Now you'll notice if the ambu bag to do the breaths is not present, just keep doing good, solid compressions, 2 inches deep, just keep going. You are not obligated to do mouth to mouth to push air into another person. But once that ambu bag is there, start that 30 to 2, start switching off back and forth. You can see from the video that some of those compressions did get a little lighter and maybe weren't as effective. And that's what happens when you keep going through a code. To my surprise, the hospital showed up. They showed up within 45 seconds. We gave them a quick debriefing of what went on. I told the nurses the importance of pulling a report to send to the emergency room, making sure that the physician knows what was going on with the patient, how they were acting that day, was there anything acute, print off the med record, the administration record, and then someone should go to the emergency room as well. The lab did show up. If they have ample opportunity to start an IV, they will absolutely do that there. Otherwise, as I said before, the goal is to find the resident, start good solid compressions, rush them to the ED. We did spend a lot of time on the floor doing CPR. We did forget the backboard to move the resident to the gurney. That should have happened a little bit faster, but the goal is to just rush them to the ED. Now, if you were a standalone nursing home that did not have an emergency room connected, you'd be running that code there until the ambulance crew arrives. And even when the ambulance crew arrives, they might be running that full code from start to finish. They might not actually make transport until the resident does have a heartbeat again. That's just kind of how it works. I think we're really in a good position here to save lives. The team did a good job today. Just keep good solid compressions going, get them on that gurney, get the AED on, rush them over. A lot of times the emergency room will bring the Lucas and they'll attach them maybe halfway, but the nurse that accompanied today said more than likely we would just put the Lucas on when we get to the ED, so someone would just keep doing the compressions. But do not forget, accompany the team to the ED. They need to know the history, and you are the historian. We also briefly touched on how to approach the topic of with family members when someone has coded. And yes, we would not pick up the phone and say, hey, mom is coded, get down here as fast as you can. You would say, hey, this is so-and-so from the care center. Your mother is having a medical emergency. We need your presence now. Are you able to come down here right now? And then if they say yes, you would direct them to the emergency room. I also confirmed that if a resident were to decease in the emergency room, that they may still have IVs and tubes and different pieces of medical equipment all around them. For some codes that I've witnessed in the past, patients have been successfully brought back to life, only to code, a half hour later. And that's just the reality of it. A lot of times you can bring a heartbeat back, but it's not enough to sustain life. One of the factors that we struggle with in a long-term care facility is finding someone or witnessing the code. If you can witness the code, you are much more apt to bring the person back to life. If it was unwitnessed, if the person was laying in bed for 45 minutes before you found them, your chances are going to get much, much, much more slim. It only takes 4 minutes of no oxygen to the brain to cause a brain injury, and those effects can last for a lifetime. So again, having those discussions with the resident when they admit is so important. People might come from the hospital full code, but upon arrival to the care center, we need to really re-examine goals of care. That is all I have today. Please reach out if you have any questions. It's always a learning experience. This was fun.